When I was a medical student, I found developing a differential to be extremely difficult, and this is an easy way that you can do it. The first time you develop your differential, it should be in front of a patient. So let's say you're in the ER and there's a 20-year-old coming in with epigastric abdominal pain. What I do now, and what I wish I did earlier, was develop the differential and talk about your reasoning in front of the patient. Just point to different parts in the body and say what can go wrong there. So this is how I would start and say, in that location, your stomach is there. Is there a component of acid reflux? Or you could have an ulcer around that tract, or your pancreas is there. Have you been drinking? Do you have a history of gallstones? Those are very common causes of pancreatitis. We can check that with some blood work, but also by your exam. Sometimes we can see that on a CT scan that we don't really need for pancreatitis. But if we're looking for other things like how's your gallbladder, that's in that location. Do you have an obstructive stone? Is there an infection of the gallbladder? Or it's a higher up from the gallbladder going to the liver? Is there an infection? Or if we go down to the bowel, you can have an obstruction in your small bowel that can be painful kind of anywhere. Of course, your appendix, is this really not epigastric, it's periumbilical. So your appendix, is that still there? Oh, you got that taken out. So probably not that because it's not there anymore. Is there an infection somewhere else in your colon like a diverticulitis? Have they been having bloody stools like a diverticulosis? Just kind of go around the body and think about what's there. I feel like in medical training, we think in lists, right? You're doing your HPI and there's the LOMNOP-QRST for time, duration, quality, all those different things. But that's more of a list. I like to think more in trees. So if they come in with abnormal liver enzymes, history of gallstones that have been obstructive in the past, go a little further down the biliary tree. If they drink every day and they've had pancreatitis all the time, think about pancreatitis. If they don't have their appendix or their gallbladder anymore, you don't need to ask all of those questions because it's not even a possibility. Now, it's important to know not to have premature closure. Just because they come in for a similar complaint doesn't mean it has to be the same thing. But when developing your differential and the pre-test probability of different things based on their history, where they look at and what's there that could go wrong, that's a good place to start. And going from a systematic approach throughout the body is much easier than rote memorization of a bunch of different things that could be wrong with belly pain. One is much more intuitive that you're more likely to remember, and the other is more memorize-y, which might be good in flashcard zone when you're in medical school, but might not be as beneficial in residency.